Well, good afternoon, everyone. Welcome to the Institute of Medicine of Chicago. My name is Lorenzo Pence. I'm the Secretary of the Institute of Medicine Chicago and the Senior Vice President for Osteopathic Accreditation at the ACGME. We are delighted to have you with us today to discuss this very important topic on mental health. This is a topic that has largely not been addressed as much as we'd like during the pandemic associated with COVID-19 and all of its variants. Today's speakers are experts and practitioners on mental health with real-world experience. IOMC is focused on real-world solutions. We are involved, support, and open to research and studies. However, solutions are what will make a positive impact in supporting individuals and communities, especially in this critical area of mental health. Talking about some of our objectives today, we're certainly going to move through some statistical highlights associated with some of these mental health issues. We're going to discover the approach by Chicago area health agencies to the mental health concerns and try to get a national view of emerging practices for mental health care during this COVID pandemic. Credit today, the program is accredited by Rush University and its strategic partners. To obtain any CEUs, please complete the post-event survey. All speakers have completed a financial disclosure and all that information is on file. And on behalf of the Board of Governors, we welcome you, we warmly welcome you to this webinar today. So thank you for wanting to attend. IOMC's mission is strong, and we are confident in our efforts as we go forward. We are celebrating our 106th year, and in June, we will have reached our 107th year as an organization. IOMC is an independent nonprofit organization of distinguished leaders in health fields who collaborate to improve the health of the public. We are proud to draw upon the diverse membership and other regional leaders to address critical health issues. So as we get started today, we want to talk about just some of the upcoming events. For 2022, IOMC has a full calendar of programs. And to mention just a few that are coming up, in March, we have homelessness is a public and healthcare issue. In April, interselectionality of education and community engagement, and it's a 4-part series. And in May, chronic kidney disease implications and trends. Now, to talk about the April program, we'll be hosted by Institute of Medicine Chicago with Rosalind Franklin University. There will be 4 virtual sessions addressing intersectionality of education and community related to healthcare and trends in healthcare trends and careers. This special series will include over 20 speakers. Overall, it will address health equity through community engagement, education, outreach, and partnerships. And then moving on to June, June 24th, we will host the 2022 annual meeting at the venue 610. We are planning an in-person event. Please save that date to your calendar. Now, just mentioning upcoming awards and award nominations. The IOMC Healthcare Awards are open for nominations right now. There are 7 award opportunities. The deadlines are May 2nd through 4th, depending on the specific award type. Please consider nominating one of your colleagues or organization this year. The awards will be presented at the annual meeting. Last year, we honored the public health directors of 6 Collier counties with a special public service award. We continue to support their efforts and commitment with continued challenges of COVID-19 and other issues. Their role is very important to their communities as it touches mental health, safety, disease prevention, other health concerns, and much more. So at this time, I'd like to introduce our panel of speakers. Dr. Maurice Lemon brings more than 25 years of health systems and hospital operations, academic affiliations, and medical education experience. He is interested in access to care issues for medically underserved populations. He has worked extensively on relationships between hospitals and academic medical centers. He is a IOMC Billings Fellow. Dr. Lemon spent most of his career at John Stroger Hospital of Cook County, formerly Cook County Hospital. As former medical officer, Dr. Lemon managed over 500 employed and unionized physicians, regulatory compliance, and the Joint Commission accreditation activities. He was also responsible for core measured performance improvements. Dr. Wanda Parker is the Vice President of Clinical and Therapeutic Services at Aunt Martha's Health and Wellness. She has 20 years of experience in behavioral health field and 10 years of higher education. Her experiences spans from being a director to at social service organizations that provide collaborative care, medical detoxification director, adjunct professor both in addictions and psychology, hospital setting psychiatric care, managed care experiences, including consultant work for MCOs and private practice work. Dr. Parker has worked with many at-risk populations such as children and adolescents, pregnant women, veterans, addictions, the forensic and medically compromised populations. And we have Dr. Karen Bettina, is a licensed clinical psychologist with over 30 years of clinical and executive leadership experience in community-based healthcare. She specializes in bringing together healthcare sectors, payers, and providers, including those that impact the social determinants of health, to create integrated delivery models focused on population health strategies that improve health outcomes. Dr. Bettina also serves as Executive Director of Healthcare Outreach and Vice President of Heartland Alliance for Human Needs and Human Rights. In this capacity, she oversees primary and oral health services, outpatient and residential mental health and addictions to treatment, refugee health programs, cross-cultural improvement services, and continuum of services. I want us to all give a very warm welcome to all of our panel today of distinguished professionals. And again, I want to thank all of them for wanting to meet with us today and provide insight and presentations. At this time, Dr. Lemon, I'm going to turn this over to you.
Thanks very much, Dr. Pence, and good afternoon, everyone. So I'm Maurice Lemon, I'm Program Committee of the IOMC, so I helped to organize today's session. We're really excited to bring this presentation to you. Mental health is such an enormous subject area that we can't pretend to be comprehensive in this brief program, but we hope this will stimulate your interest and will be the first of several sessions on this topic. Today, I'll provide a brief overview of what surveys and other research has shown us on the effects of the COVID pandemic on mental health. Now, I am not actually a mental health expert, but will turn after my opening to two panelists with us who are. But first, I think we really have to remind ourselves that mental health was, before the pandemic, and is historically under-resourced and under-financed. So no matter which specific area of mental health you refer to. So I will show data today over the last couple of years that looks at the worsening situation. The source of the data are many, most notably from the Kaiser Family Foundation, from several government entities, including the Surgeon General, Center for Disease Control, SAMHSA, the Substance Abuse and Mental Health Services Administration, and other reviewers in this area. So as I've said in the title, it's a growing demand and inadequate supply. There's a growing demand for care and an inadequate supply of providers. So here in this first slide, this is from about a year ago, a year and a half into the pandemic. You can see that the dramatic increases of adults reporting symptoms of anxiety or depression. And I just want to note, so I've put a reference here at the bottom. All of my slides, for the most part, are reference. So if you want to look more into the data, please, I urge you to read on. Next slide. So this next slide really just shows you that both anxiety and depression have been significantly increased during this pandemic in the adults that were surveyed. Next slide. So beyond mental health and beyond anxiety, depression, there are many other areas affected. Here's data from the Center for Disease Control that looked at suicidal thoughts during the pandemic. This was early on, but I think what's striking and a theme that you will see emerging in other slides is how young adults have been so much more dramatically affected than the average or older adults. So here, 2.5 time increase in suicidal thoughts of young adults. So children and adolescent mental health is also a huge area of concern. We know pre-pandemic that nearly 20% of children from 3 to 17 have some sort of diagnosed mental, emotional, development, or behavioral disorder. And of the 7.7 million children with mental health disorder, half were without adequate treatment. So COVID has worsened these. If you look at surveys of depression and anxiety, those doubled in use, both of those areas. ED visits for suicide attempts up 51% in adolescent girls. And I think that we've all kind of come to understand, and some of us very personally, that the decreased in-person interactions that children have with others through school, through social clubs, through sporting teams, through all sorts of outside activities have sometimes made it harder to identify child abuse, mental health concerns, and other challenges that are emerging in this population. We see a striking increase in adolescent use of alcohol, tobacco, and marijuana. And I think most importantly, and I bolded this, is that we just don't know what the long-term effects will be, but we know there will be long-term effects. But this from the US Surgeon General's advisory published just last year. Next. And this again points out or emphasizes what I discussed earlier, which if you look at by age group, you can see the percent struggling with mental health problems increases as the age decreases. So our youngest adult group here in this survey from the CDC, we're showing the most severe concerns. Next. Well, this is also true of the parents of children. Parents of children in households show increasing amounts of anxiety and depression. Nearly half of women with children that were in school were reporting symptoms of anxiety or depression. Next. And there's other ways you can look at this data. So this is data looking at essential versus non-essential workers. So essential workers, healthcare workers, transportation, food, agriculture, many other kind of areas. Those persons, especially in the early days of the pandemic, were reporting substantially higher rates of anxiety, substance use, and suicidal thoughts compared to non-essential workers. Next slide. Another way of cutting this is looking at income. So here, if you look at by income, those that were reporting the greatest effects on mental health were those earning less than $40,000 a year. Again, probably not surprising to most of us. Next. Well, and I think a very important topic is just how this has also affected those by race and ethnicity. So you can see, and this has been reported many studies, that among Hispanic or Latino and African American populations, the effects have been greater. Now, from this data, it's unclear. Is this because of income? Is this because essential workers are especially concentrated in minority populations? Or are these also those that have children? So there are many reasons why this may be the case, but it's clear that our minority populations are under tremendous stress during this pandemic. Next. And this shows some of the practical implications of that. So, for example, being unable to pay for basic necessities, Black and Latino populations reporting much higher rates, using up most of their savings, borrowing money, or suffering from economic consequences. All these things have been reported and found to be higher in minority populations. Next slide. So among African Americans, this comes from data from the Substance Abuse and Mental Health Service Administration. They've reported that among nearly 5 million with any mental illness and over the age of 18, 70% are receiving no treatment. Among those with serious mental illness, serious psychiatric illness, 60% or so of young adults are not receiving treatment. And those over the age of 12 with co-occurring mental illness and substance use disorders receive no treatment. So all of these things are concerning in each of these areas of mental health. Next. Among the Latinx and Hispanic population, the same sorts of issues are borne out. 7 million cases of mental health over 18, and 70% receive no treatment. Again, among those with serious mental illness, psychiatric diagnosed disorders, nearly half of those receiving no treatment. And again, substance abuse, suicidal thoughts and all have increased as well. Next slide. Well, I've told you that this is a tale of increasing demand and inadequate supply. And if you've looked at behavioral health providers over the last couple of years, if you've talked to them, you notice the enormous amount of stress and demand for their service. So this is from last summer, the health profession shortage area of the government looked at the need for behavioral health providers and felt that only about 25% of the need was being met currently. And a survey of behavioral health providers by the National Council of Mental Wellbeing just 6 months ago found that the overall demand for behavioral health services increased 25% since the increase of the pandemic. The wait lists providers show have increased even over the last 6 months during the pandemic. And I think, again, those of you with friends and others will note that burnout among mental health professionals has increased with compassion fatigue and others, obviously not restricted to mental health. Those in hospitals and other areas feel this as well, but it's particularly acute with the increasing demand for services in behavioral health. So with that, I am going to turn the mic over to Dr. Wanda Parker to talk about the experience in Aunt Martha's.
Thank you. Good afternoon. We can go to the next slide. So I did want to speak to, we have a kind of broad span. We have over 25 locations. Some are co-located at hospitals like OSF, Advocate, Amita, Northwestern, Swedish American, and some are in partnership with organizations such as Thresholds, LSSI, Little City Foundation. Next slide. So we at Martha's have an integrated model. We kind of wrap around the patient with the patient at the center of the care to provide physical health, behavioral health, and social determinants of health with care coordination weaved within. And we've been in the business of doing telepsychiatry for many years. So that wasn't new for us during COVID, which I also believe that we were able to leverage and kind of pivot fairly rapidly into other services via telehealth. So therapy, we went virtually pretty quickly. And so all of our services therapeutically were provided virtual. We were able to do some hybrid for the substance use services virtually, crisis intervention, and even some of the other programs like our juvenile justice and housing program, of course, care coordination, being able to do that through virtual means was definitely helpful so that we really didn't kind of drop the ball, lose clients at the time when they really needed the help the most. Next slide. So interestingly enough, which is really in line with the Kaiser Foundation data, is that we saw an increase under behavioral health services for telepsych. We saw in 2019, 353 unduplicated patients, but in 2020, that increased to 1,653. And in our integrated model, we have where primary care handle the lower level behavioral health needs, that's depression, anxiety, ADHD. We saw a decrease in the primary care handling those, not because they didn't want to take them, but because the cases were a lot more complex because of the the escalation during the COVID of their psychiatric needs. Next slide. And so, like I said, we were able to pivot relatively quick without missing a beat from in-person therapy to teletherapy. And one of the things that we didn't know would be a benefit was the big decrease in no-show rates then. So it was easier to access. And so we went from 40% a no-show rate to 5%. So a lot of patients were showing up, which means that the productivity was up. We didn't have as many no-shows. And it seems like pretty much in line with what the APA was reporting as well, with increases in people showing up for their appointments with the extension of virtual. Next slide. So top 5 diagnoses in line again with the Kaiser data that was shared: major depressive disorder, anxiety disorder, bipolar disorder, ADHD, and then post-traumatic stress disorder. We certainly saw for our patients who had already had a diagnosis of major depressive disorder, anxiety, and exacerbation of their conditions. But then we saw a lot of new clients that came in, or patients that came in with major depressive disorder, anxiety disorder, particularly a lot of children who had anxiety, particularly specifically around COVID and the pandemic and the impact of school. And even some of the, I think social unrest and political stands that people have taken, those were stressful, not only for the adults, but also for children as well. Next slide. So I think that we had to come to terms with some fundamental truths about telehealth, whether it was in primary care or behavioral health, is that the clinical practice that we did in person really didn't change. We still operated the same as far as our clinical practice, assessing, dealing with crises through telehealth. And good clinical practice is good whether it's in person or it's through telehealth. Certainly, we did have to have some modes of operating changes then and being able to use, but I'm also a big proponent of telehealth because it has some functionality that you can't do in person. In particular, screen sharing and being able to use the whiteboard. And, I think it just gave some other functionality that you don't have when you're in person. Next slide. So benefits to the patients that we were serving, well, certainly it was easy access to services. There was a lot of fear and anxiety for the patients around COVID and exposure. And so they felt safer. We didn't disrupt any services. So again, we pivoted very quickly. And so those that were in services were able to access them. We did have an influx of patients. And so, certainly it's a challenge with meeting that demand, with needing to bring in the talent to be able to bring those services to be, but they also were able to access those services from the comfort of the home. And so I think on some levels that helped some of our patients to access behavioral health services where they may have had some needs or some concerns before, but it was difficult for them to really kind of get up the courage to say, okay, I need this behavioral health need, and to know that they could do it from from their home, the comfort of their home, gave them a little bit more, I don't know, maybe a little bit more of a push to say, I might as well try it and do it. Next slide. There were also benefits for our providers too. Having the opportunity to work from home, either in a hybrid situation or fully remotely, was certainly a benefit. The patients were showing up. And so, our providers wanted to see the patients. That's what they're in the business of doing. And so they liked seeing that the no-show rate went down. And I think it created a work-life balance in a way that it didn't when they were just doing in-person care. Even me personally, I can say that I can go up and make a cup of tea, or in between sessions or meetings, go and sit and look at the birds or the trees. It just helped to balance out things in some way, the travel back and forth. And then we were able to see patients in their natural environment. And that to me is so beneficial. With children, they like to do, show and tell, show you pictures that they have created, their favorite toy. And I think that it also lent itself for having more family sessions or family involvement in sessions when they wanted that to happen. I'm reminded of a situation that happened, I believe in 2020. It was either in 2020 or 2021, where during a remote school session, a little girl, and you might remember that story, had been sexually abused, right? And they were able to go in and help in it. And so I think that when you really get to peek into somebody's environment, you get to see also some of the conditions and maybe even their interactions as well. It gives you a different lens that you don't necessarily have when they come into the office and they're isolated from their natural environment. Next slide. So I would be remiss if I tried to make it seem like just roses and flowers. There certainly are some challenges with telehealth, technology deserts, or digital divide for those that are served. I feel like to me, it's a DEI issue, that everybody should have access to the same services. And so that's certainly a challenge that I feel like needs to be levied. Those who serve having limited knowledge in operating technology. And so we've tried to, in some cases, give screenshots or talk them through some of that challenge for them to maybe in some ways commission a relative that has more technology knowledge to help them through that. There are some populations that it's harder to engage in telehealth, like those with intellectual disabilities, and children can also be a challenge. Although I think that, there are also benefits in the just as many challenges there are also benefits with also engaging children in ways that you can't in person. Next slide. And so to Dr. Lemon's point in the beginning that, some overall challenges were that a lot of the patients that we serve, but also our staff as well, had a decrease in social outlets and social support. So those very things that would cause for people to, in some ways, better their mental health or be able to deal with a coping mechanism for their depression and anxiety really kind of were removed during this pandemic. A lot of those social outlets were removed, and those were ways that they cope. We had patients with social anxiety that were making strides, and they were like stopped in their tracks during this pandemic. I guess the other piece too is that while I heard some beautiful things from some of the patients and how they got closer to their families during this pandemic, maybe it was out of force, not choice, but they were able to get closer and really have conversations. And through their children engaging in remote learning, that they were more engaged in their education and a part of it. So those were some of the beautiful stories. But on the flip side, there are also patients who they are in unhealthy relationships and they felt locked up with people that they didn't necessarily like or that may have been abusive. We saw a lot more abuse around children during this pandemic and substance use services. And so thinking about the things that gave them an escape, those social outlets, they were removed and now they were kind of caged. So while it was a mixed blessing, for some, it actually brought about some beautiful results. For others, it was like being in a jail. And so certainly there were increased stressors. I remember going into the store during the pandemic and seeing all the shelves empty. And as a clinician myself, feeling some anxiety like, oh my gosh, this is real. That I never thought I would get to a place where I couldn't find access tissue, or have a hard time having antibacterial wipes or gel. Those things that hit me as a clinician with coping skills. So certainly it did for our patients. And all of these things that the patients were dealing with are also things that the staff were dealing with while providing services. Next slide. So to the point of compassion fatigue or secondary trauma, that, one of the beautiful gifts that we have is to be able to connect with our patients. We served a very vulnerable population. And so there's something beautiful when you're able to make connections with people who don't have a lot of support systems in their life, but it also becomes kind of like a challenge as well for us as providers. How do we turn it off? How do we deal with our own anxiety and stressors and still be able to service the people that we care for? I have one gentleman who was newly insured during the pandemic and decided to come in to Aunt Martha's just to have a physical. He has his insurance, and so he wanted to use it. And because we have an integrated model, of course, he was screened for depression and he screened high. Did a consultation with him and found out that he was just suicidal the day before. So we were able to do a safety plan, work on some coping skills, and schedule his next therapy appointment. Communicated with the primary care provider and said, you might want to consider him having being put on an antidepressant because he has a lot of risk factors for suicide, prior attempts, substance use, complex trauma, and a poor support system. And so really within one visit, he was able to not only have a physical, be screened for depression, see a therapist, have a safety plan in place, and leave with an antidepressant. When he didn't even really register himself as being depressed. And I still continue to see him. And last year he made a comment to me, and he said that he wanted to thank me and the psychiatrist that was seeing him because he said he hadn't felt so connected or cared for. And I told him, I understand some health systems, maybe you feel like a number or person. He's like, no, I'm not just talking about it in a health system. He's saying, say, period, because I don't have a support system. I don't have supportive family or friends at all. And so it really was a wake-up call to, in that moment, that, the services that we provide aren't just health services. They mean so much more to those that are underrepresented and in need. Next slide. So one of the things that we did, or a few of the things that we did at Aunt Martha's, is we can't be health and wellness just for the patients that we serve. And so really trying to invest back also into the staff that are providing those services, right? Because the services are only as good as the staff are, right? So we have done self-care webinars, and we continue. We have some more self-care webinars on deck for this year as well, where we kind of like close down services so that they can actually partake in those self-care webinars. We've done self-care giveaways and incentives. We've added some wellness days and additional days around the holiday for the staff so that they can enjoy that time and really kind of decompress and refuel. Appreciation activities, because really Aunt Martha's is nothing without the people that work for us, right? That do the work, that are on the front lines, that are testing for COVID, and that are giving vaccines, and that are in therapy sessions and in psychiatry sessions. And so we really do appreciate all the work that all of our team does. And so also, we also want to approach not only the clients, but our staff from a trauma-informed lens, understanding that we all are sharing this trauma of this pandemic, and that we need to be able to have support, encouraging them to utilize EAP and take their days off. Sometimes that's been the opposite with businesses, is that we need you. We don't want you to go away. We're already short-staffed, but you got to be able to take care of the people that take care of the people that you serve.
So next, I want to welcome Dr. Karen Bhatia, a former colleague of mine, who is going to share with you some views from a little bit broader lens. Karen, thanks.
Thank you. Good afternoon, everybody. Next slide, please. So I want to start off with some good news, because I think when we talk about mental health and behavioral health, especially in the pandemic and all of what you've just heard from Drs. Lemon and Parker so eloquently, is that we are facing a mental health crisis in this country on all fronts for the reasons that have already been discussed. However, the good news is that the importance of mental health and the need to provide quality services is really becoming a priority. And that has been a challenge for decades. There's absolutely a recognition that behavioral health services are not adequately funded. And there's also a recognition that traditional medical and healthcare systems are starting to understand the impact of not treating behavioral health on their financial bottom line, which, as we know, really does drive a different type of practice and model of care. Lastly, payers, I'm sorry, can you go right back? Thank you. Lastly, payers are really beginning to understand as well that, that social determinants of health need to be tended to, and when they aren't connected to healthcare, that we really are struggling to have our traditional healthcare services be impactful. And so we are starting to see that get knit together a little bit more in that holistic style of care, where we're really taking care of a whole person and not just what's going on up here or in other parts of their body. Next slide, please. The really good news is that the stigma of mental illness is really starting to be dismantled. I suspect that most people listening today would say that they're probably having different kinds of conversations than they ever had about mental health, about wellness, and it really is becoming a part of our normal discourse and conversation. Next slide, please. So in terms of some of the national trends, we I think have heard very carefully laid out with the data from Dr. Lemon. The demand for behavioral health services is just going astronomically. It is through the roof. I have the privilege and opportunity to work across the country with a variety of different providers, and I have yet to talk to any clients and systems that are not struggling with how to really manage the increase in demand. The flip side to that is that the federal government and states are also just pumping tons of funding into the behavioral health system. Some of this is specifically from COVID. Others are the recognition that we cannot continue to function with the very fragmented system and the very underfunded behavioral health system as well. As we've already talked about, there is a workforce crisis in healthcare, but it is very specific in the behavioral health space as well. And that's really driving some very significant implications, especially in the public health system. What we're seeing in the mental health space in the community-based organizations generally are running somewhere between 30 to 50% of vacancies for their staff that are providing direct services. And that is an untenable position to be in the long term. Very, very common to hear, and this is across all kinds of staff. It is not just licensed clinicians. It is not just psychiatrists. It is social workers. It is counselors. It is peer support specialists, community health workers. It is across the board, and this is really impacting the ability to provide care. You combine that with the significant challenge of the secondary trauma that our workforce is experiencing, as Dr. Parker so eloquently spoke to. And it is a very challenging environment, because what's happening is within organizations, there is more and more difficulty retaining staff. People do not want to lose the staff that they do have. And as a result, access is being affected even more, because we are not able to effectively produce services in the way that we used to pre-pandemic. So a couple of different things that I think are important to highlight is that staffing models are being adapted to try to address some of these challenges and these issues. The focus really is on recruitment and retention and maximizing the staff that is available, as well as to really think about, are there opportunities to provide different types of models of care where we're really utilizing our staff in the best ability of their clinical license and their skill set. The other things that we are seeing is that behavioral health and mental health specifically is really needing to be treated throughout the healthcare delivery system. Hospitals, and particularly children's hospitals, that are facing significant crises are working very proactively at this point to try and embed co-located and consultation models across specialty services, their inpatient units, as well as within the ED and in their ambulatory settings as an attempt to really make sure that behavioral health needs are being tended to. At the same time, there is also an increased focus on outcomes and quality, which, as you can imagine, with all of the issues that I've just mentioned, become very challenging. Next slide, please. A couple of other high-level comments. There is a growing recognition in the mental health side of the service delivery system that there is significant administrative burdens that is also impacting the service delivery system. And that is particularly important in the Medicaid program and really thinking about what those implications might be for community mental health centers. There is a significant amount of paperwork that is expected and required as a mental health organization that goes above and beyond what happens on the physical healthcare side of the house. And so that is something that is being looked at from a parity perspective. We're also seeing a significant focus across the country on the redesign of the mental health crisis system of care. The federal government requested, instituted, and pushed out significant funds to create 988 lines. So that is separate and apart from if there is an emergency, a psychiatric emergency, a mental health emergency. States are expected to set up 988 phone lines and to connect those into the crisis system of care. And those systems will be coming online later this year. Again, another attempt to try to deal with what's happening. I think we've heard quite a bit already about telehealth, and I'm not going to take time to talk more about that. I do think that telehealth is here to stay. It is very, very useful, as Dr. Parker explained, for many of our patients. It also is problematic for some. And so what it means is we're really landing and having a hybrid model of care and a hybrid work environment. And so we have to be thinking about that as a system as well. We also, as I mentioned, are starting to recognize in a much more pragmatic way that if we aren't taking care effectively of people's mental health needs, that the costs of their care are significantly higher, and that we aren't able to drive the health outcomes that we are trying to get to. That coupled with the fact that when you look at mental health services, typically as a standalone service, they are not profitable. Not only are they not profitable, but typically the funding doesn't even allow providers to cover their costs. In health systems, that's a little bit different. Facility charges and as inpatient services, excuse me, often systems are able to create profitable programs on the hospital-based side, and they use those dollars to help supplement and build capacity on the outpatient and ambulatory care side. And then also the other trend that I wanted to highlight are the expansion of certified community behavioral health clinics. This is a national model that is getting more and more traction across the country. For those of you who are familiar with federally qualified health center, this is the counterpart in the behavioral health space. These are clinics that are certified by the state, and then they have very significant requirements in terms of who they are caring for, outcome requirements, and then also financial mechanisms that will allow those clinics to provide care and also provide care coordination, so they are working in tandem with primary care providers as well. That's very similar to this last bullet, which is the expansion of integrated delivery systems. And Dr. Parker just described beautifully the opportunities and what we are seeing across the country is really a drive to provide primary care practices with consultation by psychiatry. There's as well as to have on-site behavioral health workers who are able to work in very brief interventions and to help manage the short-term interventions that might be needed within that primary care setting, and then helping the primary care provider to manage medications. If those issues are not being remitted, then specialty behavioral health is often the next path. But this is a real opportunity to manage those lower acuity cases so that that can really be treated in the primary care setting where most people want to be served in the first place. Next slide, please. So I wanted to just bring this down to Illinois a little bit. And what you will see is that the trends in Illinois are exactly the same as the national trends. So I'm not going to go into these in detail again, but they are very comparable. We are experiencing what everyone else is experiencing. Next slide, please. So a few specifics in terms of Illinois opportunities. There is the continuing expansion of certified community behavioral health clinics here in Illinois. And in fact, there has been quite a bit of legislation for the state to get more involved in certified community behavioral health clinics. And that's a requirement from the feds to be able to implement some of the payment mechanisms for those clinics. So that will be an important change. I think probably everybody here is aware that there are significant efforts by the state to put dollars out to really address healthcare transformation initiatives. Many of those funded projects and anticipated projects really spotlight behavioral health needs and also will contribute to the workforce challenges because the state is putting so much money out into these projects. Most of them are hiring or contemplating hiring significant numbers of staff, very similar staff. And so we're going to see the workforce shortage here in Illinois get worse, I suspect, before it gets better. In Illinois, we are evolving our crisis system as well. And in addition, there is the implementation of health homes. Pathways to Success is the health home care coordination model that is specifically for children and young adults. Next slide, please. So I wanted to just highlight a few examples very quickly. And I think that the collaborative care model is really what Dr. Parker did explain is what is happening at Aunt Martha's. This is happening across the country is the goal and the need to really move the treatment into the primary care setting of trying to take care of patients who have anxiety, depression, sometimes more significant issues as well, but typically anxiety and depression for the most part. That model is very, very effective. It has significant outcomes. It has been heavily studied. And in fact, the model has also demonstrated that for every $1 invested in the collaborative care model, $6 are saved in the cost of care. So it is a very compelling argument from a number of different perspectives, including the fact that this is really building capacity by our primary care providers to treat these symptoms, as well as the fact that it is a better system for patients who really want to be treated in one location and by the doctors and teams that they are comfortable with. The other model that I wanted to highlight is called SBIRT, and it is a screening and a brief intervention and treatment initiation for substance use. This has been implemented also in primary care settings. We also see it being implemented in emergency departments across the country. And this is another opportunity to routinely screen to understand what might be going on, to have a quick opportunity to build the motivation to engage in treatment, perhaps provide a few short-term interventions, but then to also refer and get somebody into the system of care for ongoing services. The other trend that we are seeing across the country, and this is, I would say that mental health has been slower to the uptake. This is something that has been much more prominent in the physical health side of healthcare, which is that we're starting to see more and more team-based models of care and measurement-based care within mental health as well, specialty mental health. And what I mean by team-based models is where instead of an individual therapy caseload, that there really is a group of, usually it's 5 to 6 staff members with a variety of backgrounds, a variety of credentials, and including case management, peer supports, or somebody with lived experience, as well as all the way up to your prescribers. And often what we are seeing is that the tools that are being used are things like the PHQ-9, looking at symptom checklists, so looking at depression, looking at anxiety, looking at PTSD, to really understand these are very brief tools that are commonly used and are able to quickly assess whether somebody is experiencing symptoms. It is an opportunity for teams and for patients to be able to really better understand what they are experiencing, and to also understand progress, or if there's a need to change the level of care up or down. The last example that I wanted to highlight is the growing interest in behavioral health independent practice associations. This is where groups of organizations like community mental health centers, primary care providers, independent practitioners are coming together in new entities, literally in joining an entity, a legal entity, to be able to contract together and drive better deals for behavioral health. There are several models across the country that are statewide. There are also more regionally focused models. And I thought that I would just highlight one example from the state of Washington in Seattle and King County. The county there is a independent practice association with their provider network. They have contracted with all 5 health plans in their region, and those 5 payer contracts are then managed and financially support the system of care and the services that are happening across those providers in that network. It is a county-focused network. The county itself does hold the contracts with the payers, and then is able to really support the provider organizations. They're able to then also help to ensure that the adequate training, model of care, quality improvement, et cetera, all of those things are managed centrally and provide the back office supports to really help that network be successful. Next slide. I think that was my last one. And I'll turn it back over to Maurice.
Well, thanks very much. That was fascinating talk about some of the things that are happening. So we've summarized some of the data on COVID, the prevalence of mental health disorders during the COVID pandemic. Dr. Parker's talked about particularly some of the models that Aunt Martha uses, the integrated model, their efforts to address mental health, both in the populations and the workplace. And Dr. Patti has talked about some of this interesting national trends, and some of the things that we can look forward to over the next months and years to address behavioral health concerns. So we can go a little after 1 to answer some of the questions that people have. So I want to ask you to submit your questions in the Q&A box at the bottom of your Zoom screen. And let me just start. The first one, actually, Dr. Bhatia, you talked a little about, but the question is, as COVID restrictions begin to ease, do you have indication foresee the payers will allow the continuance of telehealth, teletherapeutic services? You mentioned you did. Can you be a little more specific about how this could be?
So we are not seeing any indication that telehealth is going to go away for many of the reasons that you all have described. Our clients, our patients are demanding it, and if you think about yourself, how much easier it is to have a telehealth visit with your own provider, our clients feel the exact same way. What we do think is the potential to go away is I know in Illinois, we can provide phone only services, and we suspect that may go away eventually, but there is no indication that telehealth will be eliminated.
Thanks. And well, hoping that the infrastructure bill that's out will address some of the access concerns that Dr. Parker referred to, because among our poorest populations, we see those without access to internet and others are potentially left out of some of the positive trends in this direction. Okay, we have another question that says, could anyone speak to how you're trying to motivate staff to continue this difficult but important work? And I would ask, we know you've talked to or alluded to burnout, but what kind of turnover are we often seeing? I know in nursing particularly, there's a huge amount of salaries are going up, attractions for staff nurses to leave and take temp jobs or other things have increased. Are those same things happening in behavioral health care as well with respect to these issues? So maybe both of you can address this. Dr. Parker, do you want to start?
Yeah, I mean, certainly there has been challenges with attracting those that are providing behavioral health services for sure, and we've done some things about adjusting salaries. But and really bringing in talent, but we also want to work really hard to try and keep the people that we have so that we aren't just kind of like running the same and not really gaining any traction. So I think, what we've done is the really investment in health and wellness then, instead of trying to prevent people from taking days and saying, hey, this isn't a good time, encouraging them to utilize their benefits package. Increasing that and giving more days, around the holiday time when you really need to refuel, but it can also be stressful, and summer days, so we really, really try to look at what would be beneficial to kind of offset some of the stress. Having an employee assistance program, do more trainings too around the services that they provide so that they can utilize or somebody in their family can utilize. Really trying to really invest in being creative. And I think we're constantly talking about ways to really be able to motivate staff, to let them know that we hear them, that we understand. Being able to, in some cases, some people are saying, okay, I don't think I want to do this full time, and having the option to do part-time until they kind of refuel and come back. I've had one clinician who she wasn't practicing good self-care, and she took some time away, but she came back because she liked being a part of our system and the work that we did, but she came back equipped with some better self-care mechanisms then, right? And I think that it's providing trauma-informed clinical supervision, right? So that there's this built-in self-care mechanism that we're talking about, and that's just as important as productivity and everything else. And so I think it's really changing the lens of caring for the people that are caring for the people. And we try to do that in different ways, incentivizing, listening to them if they need time, encouraging them if they need time. So those things I think has helped for us to retain to some degree, but having some level of flexibility as well.
Yeah, thanks. And before I turn to you, Dr. Bhatia, just a couple of other comments have come in. Question: how do the unhoused, I guess the homeless, access telehealth? And how do you measure the effectiveness of telehealth? So again, a lot of interest in that area.
Do you want me to speak to that, or Dr. Bhatia?
Dr. Bhatia first,
Okay.
and then we'll see.
So I want to just answer the other question as well, just to add to what Dr. Parker said. We are hearing stories repeatedly from all over the country. This is not isolated to any one region. Salaries are being increased multiple times in a given year. Retention bonuses are being paid, incentive packages are being increased, signing bonuses are being increased. Not terribly effective in terms of really managing staff, keeping them in your organization or ready and able to do the work. I think many of the strategies that Dr. Parker has discussed are being employed elsewhere. And it does help significantly, but it is changing the nature of how the work is done and what leadership needs to do to be responsive. So I did want to highlight that as well. In terms of people who are unhoused accessing telehealth, there are a number of different mechanisms. I mean, one, many people who are experiencing homelessness actually have smartphones. More often than not, it is not unusual. And typically, that is a mechanism that can be utilized. We also see that many of the provider systems have set up telehealth rooms so that somebody can actually go to the facility and participate in a telehealth visit remotely with their provider if they don't have internet access or privacy, because that is an even bigger issue that we are hearing about, especially with young people who have parents in their homes. We have many people who are housed who really are on top of each other, and so it is very, very challenging to have private space as well. So there are a number of logistical issues. And so we've seen many health systems setting up spaces for patients to come on site. In terms of measuring the effectiveness of telehealth, I think there's a growing body of literature. It is certainly something that you have to match it to the population. We see that it's very difficult and challenging with people who have cognitive issues. It's challenging for people who are older, like myself, who might have technology challenges. So there are a number of things that we need to really be sensitive to, but that body of literature is really starting to be developed. And I think it's a little early to tell in terms of an outcome perspective. But I would point back to Dr. Parker's comment, the clinical model is relatively the same, whether it's telehealth or in person.
Dr. Parker, you want to add to that?
Well, and I was going to say the same thing, that we would measure it the same way, right? Because what we really want to know more than that telehealth is effective is that the mental health treatment is effective, right? And so those things are measured the same. We do PHQ-9s. Are their depression scores going down? Are their anxiety scores going down? Are they experiencing less symptoms? Are their well-being checks really kind of going up? If they're using substances, are they using less and or abstinent? Those are the markers for the treatment being effective, whether it's in person or through telehealth. And so we would measure that the same.
Here's another question that's kind of related in a way. The question reads, health system administrators have shared that they're not able to bill for the 30% overhead that gets covered by in-person visits, and so are actively discouraging remote care for mental health. Is this effect being measured in Illinois? Either of you want to address that question? Is that your experience?
I have not heard or am aware of that in any way. The telehealth visit has, depending on what the billing codes are, does provide a similar reimbursement for most services as in person. So I'm not sure what the distinction is.
Yeah, and I would say the same. Now, granted, when you make the shift from in-person to virtual, then you have to utilize some other modalities or, technology. And so there's some money that has to be invested in that way. But
Mhm.
no, I mean, I think that, what we saw is exponentially services going up, and it actually helps, right? When you don't have people that are geographically bound, as far as you're able to kind of broaden your talent search. So it doesn't necessarily have to be someone who lives in the south suburbs. They just need to be licensed in the state of Illinois and able to do services. That actually increases the talent search. And so in ways that I think are more beneficial than not, telehealth broadens that. And one of the other things, and this is kind of a sidebar, but I think is benefit to say, is that when we went from in-person therapy to teletherapy, we were able to really kind of do better matching for the patient. So if I have a clinician who is certified in addictions as well, but she's located in, Southern Illinois, but I can still match that patient with that person, or the person that has a specialization in domestic violence or is able to do DBT, or some of our clinicians are trained in providing trauma therapy. And now we're not geographically bound, and we can do better matching for those patients to get the, services that they need.
Well, here's a question that kind of comes from what you were both speaking of, which is the shortage of behavioral health providers. The pipeline for psychiatrists and psychologists, it's 4 years of training. And so you've talked a little bit about how other behavioral health providers are being used. Do you see ways that these resources are being funded or directed to help generate more providers or cross-train providers to work in behavioral health, as we're going to see this shortage of behavioral health providers on the horizon?
I can take that one. I definitely is there is no easy fix, and you're absolutely right. It is a long glide path to making sure that you have the workforce that is needed. It's I think it's a multi-pronged strategy, and that states and systems and counties and cities are just starting to grapple with. In Illinois, there has been a dedicated workforce for behavioral health strategy that is being funded by the state, and is a partnership with an academic institution that will start to look at what some of those strategies are. Another example to offer is the state of Washington actually just had in their budget, this has been introduced and expected to pass $100 million in their budget to go directly to behavioral health providers for workforce for training. Now, that will be more on the ground and is not the pipeline that you're talking about. But I think that people are starting to get more and more creative about what needs to happen. It is especially important in terms of thinking about diversity of our clinicians. We really have a shortage in clinicians and trained behavioral health experts who are from the communities where people are really struggling with health equity issues. And so that is also a priority, I think, for our system.
And I guess I would just add that, I think loan forgiveness programs, especially for the, in the FQHCs, that's an appeal. And then it's just an investment, right? I think in order to get a return, you have to invest. And so I know we've invested in training our clinicians to get certified in trauma models and integrated care models. Those investments that, God forbid they leave, we hope that they don't, but if they did, that they left out with more than they came in with, right? And so, and I think a lot of times it helps for people to stay connected and plugged in when they feel like that company is also pouring into them as well.
Well, I think that's the end of our questions session for today. So I want to personally thank both of you for your insights and experience that you've shared with us. It's been a really fascinating program. Just a couple of, yes, Dr. Pence, I think wants to.
I was gonna, again, I was gonna also thank all three of you for your input and presentations today. I think you gave us a very broad look at the needs locally as well as across the country. Also, I think some of the successes, not that there's not been many challenges, but there have been some successes in how one looks at some of these issues and how society is looking at this, and also potentially associated with funding models that may actually help things in the future, although everything is so slow. But at least we're moving in a positive direction. You know, and also talking about all the various providers. I'm a family doctor, I'm a primary care doctor, and I can tell you, as you note, that there's first liners as far as seeing a lot of these folks. And just trying to understand this, the models that are out there that can help. A challenge from my experiences in practice is it was taking care of people and you took care of all the folks that came in, but it's when you were challenged with someone that needed more than you could provide, and then finding not only the providers or, you know, the professionals to take care of them, but also sometimes the facilities. In an urban area like this, there's many choices, but still things are still tight. I come from rural areas and it's even more difficult because there's fewer providers and certainly not as many facilities. So all those things need to be addressed. But I think y'all touched on so many good things today, including the federal clinics and how that would, you know, fits into all this associated with some of the care that will be given there, and also how some of the costs are covered. So again, thank all of you for everything you talked about today. Very impactful as far and insightful as far as some of the needs. So thank you for all you do and giving us that perspective. So thank you.
Thank you.
Right. So I want to remind everyone, the Institute of Medicine Chicago Healthcare Awards closing deadline is May 4th for those submittals. I want to thank everyone for attending today's session. We hope to see you at the next virtual session. That's March 25th on homelessness as a public health and healthcare issue. And follow us on LinkedIn, check our blog, or visit our website for more details. So thank you again, and have a good day. Have a good weekend.
Bye-bye.
Thank you.